Hello everyone. We will start in a few moments. We'll just give it time for everyone to join. Welcome to today's webinar, Failure to Thrive, Rehabilitating Long-Term Care. My name is Romilly Douglas and I will be your moderator. I'm pleased to introduce today's speaker, Irving Stackpole. Irving is the president of Stackpole Associates, a strategy, marketing and research firm he started in 1991. Irving has decades of experience in healthcare and senior living. Before I hand the mic over to Irving, I have a few housekeeping items to cover about this presentation. First, today's webinar is being recorded and will be made available by email to all participants after the webinar for further review and sharing. Today's webinar is accredited for NAB ENSAs, and for those who want their attendance to be marked, please either message me here or email me in your full ID with name. We'd love to hear from you during today's presentation, and we'll be answering questions at the end of the session. If you have a question for Irving, please send it through the Ask a Question tab at the bottom of your player. If we don't get to your question today during today's webinar, we'll be sure to follow up afterwards. So without further ado, I'd like to kick things off by welcoming Irving. Thank you.
Thank you. Thank you, Romilly, and welcome everyone. It's a real pleasure to be here with you, and thank you for taking an hour, at least I hope it's an hour, out of your day, your valuable time. And my hope is to make it worthwhile and to further the dialogue about long-term care in the United States and the UK. I've used the title Failure to Thrive as an homage to one of the papers that was produced back in 2014, I think, that first scoped out for me the real difficulties involved in the long-term care sector. Failure to thrive generally describes a complex array of chronic conditions which in an aging person result in a general deterioration and a general failing in health. And I believe that that situation describes what's occurring in long-term care very accurately. What I'd like to talk about today is the current situation, as well as what might happen regarding recovery. The news hasn't been good, continues to come in pretty difficult tranches. This was an article from one of the New Yorker magazine supplements, The American Nursing Home Design is a Failure. And while I disagree with the glib nature of the article, I must say that it's generally not untrue. What we're going to talk about is we're going to talk about structures, programs, technology and information systems, means of production, which in these markets means labor, culture, and outcomes. And we will talk a bit about economics and how they are impacting this failure to thrive in long-term care. Please understand that I'm fond of definitions. They describe generally where we start and how to deconstruct a problem. And this is nothing less than a crisis. And a crisis, of course, is an adverse event which has an impact on your brand. And the brand long-term care, the brand congregate care, nursing homes, all of these brands are being damaged badly in the current pandemic and the aftermath. The question, of course, is what can we do to save and salvage what we can from the sector? Now, for those of you who are in long-term care and in particular in the nursing sector or the care home sector, nursing homes in the US, care homes in the UK, what you're wondering, of course, is whether the market will recover. and of course the question is, it will, won't it? There are durable segments to the long-term care markets, and these are in the skilled nursing and nursing home environment. The durable segments are those consumers who have no choice. These are individuals who are poor, very sick, often with neurological or neuromuscular diseases, or with memory loss, such as Alzheimer's or cognitive impairments that are not dementia. These individuals will continue to require congregate care. So these segments aren't going to go away, as they say, anytime soon. Not so much for assisted living and home care. These segments are having a different reaction, a different consequences, the result of the pandemic. Assisted living residences, for many, the intake has stopped and the departures have slowed. So there's some stabilization there. I've even talked to some clients who have reported to me that they are admitting consumers to their assisted living residences. I think these, however, are the exception rather than the rule. Home care, on the other hand, is indeed experiencing a very serious, very significant growth in interest. The real question with home care is labor and the means of production, and we'll talk about that in a moment. The other thing that we'll look at is the likely recovery models. I've done some mathematical modeling to show what I believe will be the recovery rates and patterns in both skilled nursing or nursing homes and assisted living. And the recovery, the actual recovery, depends on the depth, length, and the shape of the recovery. I think we have two basic scenario options. And I've reviewed this in my prior programs, which I hope you will access as well. One is that the sector will be rebuilt and recharged. Certainly we see some signals of that, although after serving in this sector since 1985, forgive me if I'm a little skeptical. And the other scenario is that this sector will be further ravaged and relegated, further neglected politically, and used as a football for all of the excuses. That's in large part what this article is about from the New Yorker. It appeared in the Intelligencer, saying that long-term care, congregate long-term care, and in particular nursing homes in the United States, were the result of a collision between poor policy choices, 1965's era, mid-1960s era construction, and real estate profiteering. I commend this article to you. It makes for tough reading. I don't agree with all of the things that the author was stating, but it is indeed a sobering look at the dimensions of the problem. On the other hand, we have people from Harvard School of Public Health, Dave Grabowski, whom I have enormous respect for, saying that we can look for big changes to the nursing home regulation as a result of the pandemic. Well, I have a couple of questions about that. First is, let's define big. I may have a very different idea of what we mean by big, and I'll introduce some changes later in this presentation, which I would suggest are big. And then the issue of nursing home regulation. Now, it's been said, and I believe this is true, that nursing homes are more heavily regulated in the United States than nuclear power plants. I've certainly seen the shelves of regulatory manuals on my clients' offices' bookshelves, and each of them has some element that needs to be observed. It doesn't make a shred of sense to me to take a sector that is fundamentally on the brink and to add more regulation. In fact, if anything, we need to remove regulation and more carefully evaluate what can and should be done to save the sector. Well, I've promised some arithmetic or mathematical reviews of what I believe will be the recovery pattern for skilled nursing, and this is what I believe it is. Current penetration rates of the aged population segments is roughly 1.6 pre-COVID. And the question is whether we'll ever get back this loss in the market demand, the market acceptance for skilled nursing. With assisted living, the pattern is different. There will be a recovery. There will be a loss in some confidence, loss in trust, and loss in market voice or market share for the sector, but that will be marketplace by marketplace and very much driven by how those managers in those marketplaces manage this particular crisis. The domains I'd like to talk about here are the physical structures, the programs, so the built environment, the programmed environment, technology and information, means of production, which here means labor, culture, outcomes, and economics. First to structures. The original PPE was property, plant, and equipment. Most of the nursing homes in the United States were built between 1960, actually 1965, and 1975. They were modeled, they were Hill-Burton, they were resulted from the Hill-Burton Act. They were modeled on hospitals, long straight corridors, efficient for the caregivers, but not very attractive for the consumers. Assisted living, on the other hand, is a relatively new construction, new product in the United States and in the UK. So the product is newer and it attracts a market rate consumer and family member. Since then, and the assisted living market started in the early 1990s. Since then, especially in nursing homes, there's been little or no reinvestment. Capitalization in the sector has been extractive, meaning that the capitalization the capital formation which has occurred in the sector has been extractive. People have removed, organizations have removed money from the sector through a variety of mechanisms, and the federal government has withdrawn fiscal support. Now, the federal government supports the sector, the nursing home sector in particular, through the Medicaid program, and the assisted living sector partially through the Medicaid waiver program. But the federal government pretty much washed its hands of long-term care decades ago when it realized that at the trajectory it was on then, it couldn't support the sector. The result, I've said here, yuck. The current author of the article about the American nursing home market says it's a bad design model, it's a failed design model. And my question here is, would you stay in a Hilton that hadn't been renovated for 40 or 50 years? Well, no, you wouldn't unless you had to. So what do we need? First of all, we need a wide array of physical structures to accommodate the needs and preferences of many different populations. The population that should consume and would consume congregate senior care is not a monolith. They are finely segmented groups of individuals in most of the marketplace areas, some of whom prefer large buildings with many units, and some prefer small buildings with only a few units. There's been a call recently for smaller structures, mostly in the wake of the rapid movement of the pandemic, the infectious disease, through congregate care centers. The line of reasoning going, and there's some evidence to back this up, that with smaller properties, infectious diseases move more slowly through the population. And while that's true, it's very, very difficult, as many of you know, to make these numbers work. A big part of the work that Stackpole Associates does is around market analysis and feasibility studies. It's very difficult to make small unit like greenhouse model assisted living or skilled nursing units work financially. Large like college dormitories with attractive common spaces will be appeal to certain segments. Medium size like assisted living residences will appeal to other market segments, and small like McMansions for small groups of related, unrelated individuals. Think Golden Girls as an example. Supply studies have been benchmarking, but not qualitative analysis. What can the investors extract versus contribute? The real estate undergirds this sector. So the questions are, what can we do to invest in the sector with the proceeds from those investments staying in the sector? The other issue for structure, and this is an overlap, is telecommunications and information infrastructure, which is extremely poor in the vast majority of nursing homes and moderate to average in most assisted living residences. And the critical issue here is access to capital. Who can afford this stuff? Only people who can access capital. And in the current environment, with occupancies down, with the admissions slowed to a creep in most locations, accessing capital promises to be even more difficult in the near term. And we can watch these patterns working themselves out in the capital markets as well. Why don't we get what we need? Well, first of all, we need a new federal Hill-Burton Act. So we had the Hill-Burton Act, and the Hill-Burton Act was a way to populate the United States with healthcare, hospital, and nursing home providers. And it succeeded. There's no reason we can't do something similar at this time. The United States and the UK have flooded the capital markets with cash. There is an opportunity here to carve out some pieces, to give access to capital so that nursing centers in particular, and even assisted living residences, can rebuild to better accommodate the populations that are with them now and are awaiting in the wings. The other reason why we don't get what we need is that the existing operators have a pattern of competing with each other. So there's little collaboration state to state with the state assisted living residences or nursing home operators going to the policymakers in order to plead their case for what's needed. And I'm not talking about a day on the Capitol Hill, the American Healthcare Association or Leading Age pleading for more money. Once the bleeding is gone, the pleading is over. What we really need is we need a collaboration, cooperation to focus on what we need. And I'm going to talk further about that in addition to access to capital. The sector has focused on profit, not the future. So many of you are dealing with existential threats to your operations. The days cash on hand in the sector by several studies was a pittance compared to what it is in many other sectors, which means that the nursing homes and assisted living residences, but nursing homes in particular, had very little resilience for such a supply and demand side shock as we've experienced. And finally, I'm going to say it pays to confuse the consumer. We have done a poor job in the sector explaining to consumers how to navigate this incredibly complicated long-term care system. I'll talk further about that in terms of what I think we can do that's truly disruptive and a big, big change. Also, providers don't bargain together. It's true that there are associations. There's Leading Age, the American Healthcare Association, the American College of Healthcare Administrators, and others. But seldom do we see them truly going shoulder to shoulder and taking a stand on policy issues or taking a stand on innovations which would truly impact the sector. And I have to ask, having been an employee of an organization that enjoyed the real estate investment trust benefaction, the question is, do we need this arrangement in the sector at this time? And is there a way to migrate toward a more reasonable arrangement around how the property is held versus how the operator pays rent. Next, I'd like to move on to programs. The programs in long-term care are fundamentally broken down into two verticals. One is locationally based programs, and the other is need-based programs. And these are community-based, home-based, they're congregate, they're nursing, and more. They're social-based. Some of them are in between ISIPs and PACE. How on earth did it get this complicated? We get calls on a regular basis from family and friends who are confused, don't know what to do, don't know how to navigate the system, and can't decipher the language. If the consumers and their families don't know what they want or need, why aren't we, the providers and the organizations that represent the providers, why haven't we been teaching them? Why haven't we been explaining the difference between home care and the difference between nursing home care and home care, between hospice and home care? And can you get hospice while you're in skilled care? Can I get home care and then go into skilled care? I don't understand why these are not being explained through the sector, through the providers to consumers in the marketplace area. So what do we need? I'm going to suggest that we wipe the eraser board, wipe the blackboard, and focus on three things. One is that we need screening and triage. We need a way to identify what it is that people need using objective evidence-based criteria, and then directing them to those channels so that they can access those services. The second principle is to fit the person to a program, not the payment. Most people are directed into particular programs based on the coverage that they have, the insurance coverage they have, or the types of payment systems they can access. This, to me, is completely backwards, and I expect it is to many of you as well. And the third thing is clear, understandable choices. And my comment here is credit default swaps are simpler than long-term care choices. And maybe we need the movie The Big Short, which I thought explained credit default swaps quite cleverly for long-term care. Technology and information. The status of technology in long-term care is nothing less than embarrassing. And some of the very early difficulty and pained conversations with families about their inability to get information, the outrage in the popular media, the popular press, about the inability of the sector to provide accurate information, is the direct result of the fact that we are the sector that modern healthcare technology left behind. The technology that is in place is focused on recording and regulation and reporting, not on efficiency, not on staff efficiency, and mostly on who can afford it. So the more upscale nursing centers, the nursing centers that had the better quality mix, the assisted living residences that had the more higher paying populations, they could afford it, so they had this stuff. The bottom line is that most grocery stores have better technology than long-term care providers. So what do we need to do? The first is we need to have a priority that puts granny over tomatoes. Second, we need to look past things like personal emergency response systems. Help, I've fallen and I can't get up. That's just not the kind of technology that's needed for today's environment. And the legacy hospital-based systems are boat anchors. They're like rotary phones in the day of mobile phones. What we need is an internet of long-term care. We need real electronic health records that stretch across and through long-term care providers and that connect through interoperability interfaces all long-term care providers, and I mean all of them. the pharmacy providers, the home healthcare providers, the DME providers, the physicians, everybody. And then we need to look at something like that's being called ambient assisted living and how that will help our seniors gracefully and more healthily age in place. So the means of production, the people, the question is, who cares? Well, there are a lot of people who do. Non-paid and paid caregivers. The question these days is who wants to work in long-term care? This is an enormous question of immediate and exigent existential urgency. We need to be looking at the effects of the pandemic on the sector, on the means of production, employment in this sector. We need to consider what the sources have been up to this point and what the sources will be in the future. I talked about the means of production or staff serving in long-term care before. This is the latest data from Kaiser Family Foundation. There are about 4.5 million long-term care workers in the United States, and you can see here how they break down where they work and the types of work that they do. Almost over 40%, and this is pre-COVID now, over 40% worked in skilled nursing facilities. It'll be very interesting to see what that proportion is and how this particular pandemic impacts those proportions. So what's possible with regards to people and staffing? So the first question is, who wants to work in long-term care? There really are people who do. And it will take probably a generation to remove the stigma associated with working in long-term care. But I say, what are we waiting for? We should begin to do that now. Second, this is a disruptive innovation. We need a federal long-term care jobs act. This would allow us to release federal funds to retrain the roughly 10 million people, or a selection of those people who are currently unemployed, whom I would propose should be screened for personality traits, other qualifications, and for loyalty, interest in, and commitment to the sector. We could use existing training centers, and salaries need to be subsidized with suitable retention incentives. It doesn't make any sense to go to the State House and plead to your Department of Health and Human Services for more money to pay people when those people are just coming through like they're churning. They're coming in and going out, coming in and going out. That to me is a very poor investment, and I don't see how politicians are going to sign up for that. Culture. The culture in long-term care has been difficult at best. This is a rather dire picture of an environment in a long-term care center, but I'm sure you can all identify with this. Culture isn't something that you put on like a Band-Aid over an operation. It's something that's grown organically. And in all the survey work we've done around the United States, we can identify, based on leadership characteristics, where the culture is apt to increase retention and loyalty among staff, and where it's a hindrance to loyalty and staff. So I want to focus on outcomes as well, because we put up quite an inventory of things to be reviewed, and outcomes certainly needs to be considered. In the current quality, the QRP environment, the new data requires clinical results, which I would argue is only part of the story. So quality isn't necessarily a non-adverse outcome of a clinical intervention. Quality is the degree to which the service is free of defect. And who determines what a defect is? Well, certainly clinicians are in a position to evaluate whether or not weight gain or weight loss is a defect, but so aren't the family members. The family members and the consumers themselves are in the best position to tell us if the service we've offered is free of defects. In assisted living, it's common and routine for assisted living operators to survey family, residents, staff, and to evaluate quality in a pretty rigorous way. This has been done less frequently, less rigorously in nursing homes and other long-term care settings. Consumer satisfaction means, what do consumers want? What do they need? And what do their families want? And if they don't know what they want, why aren't we teaching them? This goes back to the first point about damage to the brand and the difficulties around the complexity of programs in long-term care, because we as a sector have done so very little to train our audiences about how to access our services and how to differentiate between what I need today, what I might need tomorrow, what's good and what's poor. Now we come to economics, which is usually where people start, but it's really at the end of the line. So there are direct and indirect costs. Basically, the systems have been shortchanged for 30 years. We in the sector have put up with this in part because we've been able to cross-subsidize our operations by having a few private pay, a few Medicare, and then lots of Medicaid. And those few private pay, Medicare, and maybe some managed care, that has cross-subsidized the losses we've all tolerated in Medicaid. Now that the water has drained away from the stanchions holding up that structure, the rot is apparent and it can't continue. Medicaid cannot afford long-term care the way it's currently structured, the way either Medicaid is structured or the way long-term care is structured. It's simply a non-starter. Medicare backed out 30 plus years ago, and consumers still today think that the government will pay for long-term care. And this, in spite of the fact that the United States alone enjoys about almost $500 billion in value for non-paid care. These are family and friends who care for the sick elderly person next door, across the town, or across the street. There's also waste, misdistribution, lack of collaboration, and fragmentation. All of these things contribute to the crazy cost model in long-term care. So here's some ideas that I want to float in order to get what I think we need in long-term care. And it's just, right now, it's what I think we need. I believe there's general agreement about some of these things, but my sincere hope is that this presentation, along with prior presentations, is really just the beginning of a discussion, a meaningful discussion, not about changing the color of the Band-Aids or rearranging the decks on the deck chairs on the deck of the Titanic, but really figuring out what it is that we need. First of all, we need a federal insurance program for long-term care. This is not rocket science. Every other OECD country has this. Japan did not. Japan faces an even more challenging demographic cliff than Europe or the United States. And Japan introduced long-term care insurance in 2010. And if they can do it, we can as well. We need a federal insurance program for long-term care. It's been introduced several times. It's been talked about, but as I suggest here, it's always the bridesmaid, never the bride. Funding. It would be funded through a small increase in Medicare payroll deductions and small premiums with a means test. So this would be progressive, small progressive premiums on Part A, Part C, and Part D Medicare. And yes, ladies and gentlemen, this will create a kerfuffle, but we can afford this, really. Also, private long-term care insurance should be fully deductible. Private long-term care insurance has never reached a penetration above 12% in the United States. Its rate is a little lower in the UK. There's several reasons for that. And part of the reason is that consumers don't believe that there is a serious funding gap facing them for either their care in long-term settings or the care of their loved ones. So we need private long-term care insurance, fully deductible, and we could create, this is what was done in Japan in part, create long-term care risk pools, but in each state. So each state would have its own long-term care risk pool and require those participating private long-term care insurance companies, that's health insurance providers, to spend a small fraction of 1%, half of 1% of the premiums on education communications to catch up with what the sector hasn't done to teach consumers and the general public how to access our services, what they need, what's good about private long-term care insurance, what's available through public long-term care insurance, and what their options are in terms of programs and needs. So that when mother falls, when Mrs. Stackpole falls and breaks her hip at home, young Mr. Stackpole isn't calling around frantically. He or his other significant other know who to call. They know what to do because they've heard about it, they've read about it, their friends have talked about it. They've talked about it at dinner parties if we ever get back to having dinner parties. So the next steps. I think the next step is to look past the current situation, accept that it's a complete design failure. It's, to use a famous author's term, it's a FUBAR. So next step is to look at a community of action. It isn't just policymakers. It isn't just providers. It isn't just people in the federal government. It's all of us. We need to address this, and the consequences of not addressing it are relegation and a very, very bad situation. There'll be hundreds of nursing homes that will go bankrupt when the cash runs out and they don't have any consumers knocking at their doors. We need an effective dialogue that includes all options, looks at the options, and sorts them out at both a state level and at a federal level. Washington State has introduced long-term care insurance, public long-term care insurance. Let's look at that model, see how it worked. Let's look at the Japanese model. I hope we don't have so much hubris that we can't look across borders for suggestions and ideas about what might work in the United States. And frankly, ladies and gentlemen, that's what leaders do. I'm calling on all the leaders in Leading Age and American Healthcare Association, the American College, to step forward, to engage in these conversations, and to move the sector forward. The world we have created is a process, it's a result of our thinking. It can't be changed without changing our thinking. There's no scapegoats. We arrived at the current situation through a series of well-intentioned individual decisions, a series of hundreds, maybe thousands of decisions about coverage benefits, inclusions, exclusions, payments, funding, good research done, crummy research done. We've gotten here through these decisions. We need to accept that and move on, because the future without serious, significant change in long-term care isn't very attractive, ladies and gentlemen. And many of us are going to look to a system that either isn't there, is too affordable, or is frankly unacceptable. So with that, I'm going to thank you all for participating and take whatever questions there might be from the audience.
Thank you, Irving. Thank you very much for your presentation. So now let's open with the Q&A session. Firstly, what about staff shortages? How can we recover from these?
What a good question. So staffing in long-term care has been a problem, and historically before the pandemic and during the pandemic, the pattern of staff who are overwhelmingly women, many of them are immigrants, many of them work multiple jobs, including multiple jobs in long-term care. These caregivers went from building to building, or from home to building back to home and served as vectors for the illness, for the SARS-CoV-2 virus. So what we need a model that can replenish the supply of staff, which has been dwindled, and we need to do it very quickly. The most immediate source that seems available to me are the unemployment rolls. There are currently over 10 million individuals who are still unemployed, and I believe that they could be accessed for service in this category. And there's some initiatives around this. I believe in Connecticut, there are now stipends available for individuals who choose to work in long-term care. And I don't know whether the stipends go directly to the individual worker or to the operator, but these factors need to be sorted out, and it will take a concerted effort on the part of operators, the unemployment benefits team in the state, as well as the leadership organizations, the American Healthcare Association, Leading Age, and other groups whose interest should be in meeting the needs of frail elders in their communities. I hope that answers the question.
Thank you very much. So the next one we have is, will families recover their trust of nursing homes after COVID?
That is a good question. I've tried to model this in my recovery models for the feasibility work that we do at Stackpole Associates, and we have to include a range. Some families in some marketplace areas will recover trust very quickly. In other marketplace areas that have been more heavily impacted, will recover more slowly. So I think they will. I think initially there's certainly quite a few people who need long-term care. And my hope is that by addressing the staffing shortages, funding requirements, and other factors, that we will restore and renew long-term care in our communities and thereby restore trust in our providers.
Thank you, yes. And the next one is there the political will to make the changes you have outlined?
That's really a question. What a good question. Is there political will? So I see it in some places and I don't see it in other places. My overall take is that there is not. There was a presidential commission, a blue ribbon commission appointed to look at the impact of the novel coronavirus in long-term care. Commission issued a 186-page report, and of that 186-page report, a page and a half, double space, were a set of recommendations. Those recommendations were not very disruptive, not very challenging, and I think somewhat PC, somewhat politically correct. Now, if you were on that commission and you're on this call, I apologize if I've got your nose out of joint. Call me afterwards and we'll work this through. The report is available. Don't take my word for it. The report is available on our website. Look on the resources page and you'll see it there listed. I don't know that we have in the United States the political will to deal with this. My fear, my concern is that we will end up with a sector that has a huge hole in the middle of the United States, where those individuals sadly have to travel hundreds, maybe more miles to find a suitable, adequate long-term care, congregate long-term care solution for their family member. And that would be just not a good outcome.
Thank you, Irving. Next question we have is, your recommendation on tax deductions for long-term care. Please expand on this, especially in light of the current insurance policies.
So the tax deductions on long-term care insurance, private long-term care insurance, those premiums are tax deductible for most people. But unfortunately, that was a battle that was fought long and hard. And as best I understand it, the people who launched that battle were from the long-term care insurance industry. The battle didn't succeed quickly, so that many of the people who attempted to buy long-term care insurance weren't initially able to deduct all of the premiums against their income or other earnings. And because of that, the general understanding incorrectly became that these premiums are not deductible. The long-term care insurance business also, there was a flaw in their model as well. The major long-term care insurance providers in the United States, I can't speak to the ones in the UK, I'm just not familiar with them, but the ones in the United States got the actuarial model wrong. And because of that, their loss ratios were unacceptable. And so many of those long-term care insurance providers have withdrawn from markets. The cost of staying in the long-term care insurance market is high. The benefit is to the insurance providers is relatively low, and so many providers have folded up their tents and gone home. Part of the reason for this is the lack of understanding in the general population about how to access services. The long-term care insurance market tried to educate people to raise the issue, the prospect of how they would care for themselves or their loved ones when the need occurred as they got older, and did not succeed. Not enough was invested in it. There was no collaboration, coordination, except perhaps with AARP to speak of. So those markets didn't get the kind of penetration that would have helped significantly to keep those players in the game and to help orient the consumer market in the United States as to what a long-term care insurance policy is and what it covers. So now we need to take a really disruptive new approach.
Thank you, Irving. So we have time for a couple more. So next one is, what can consumers do to promote political will?
There are roughly 15,000 nursing homes in the United States. There have been about 1.5 million consumers resident in those nursing homes. If every single one of their families and friends were mobilized, that would represent a significant force against the political neglect and political indifference that currently exists. And I should caution that or qualify that statement, the political indifference and political neglect. This is historical. Right now, what we have is mostly hysterical. Everything's going wrong in long-term care. 42% of the fatalities in the United States occurred in congregate long-term care settings. And this is raising everybody's concern. What there isn't is a groundswell from the population most affected toward the political leadership to create meaningful change. So you can't just motivate somebody without giving them a direction. A directionless motivated person is dangerous. So we need to give people direction, and I look to leadership in organizations, even as commercial as AARP, but certainly the long-term care associations, the organizations that represent the providers and the caregivers, and there's a good 15 or 20 of them, which if they coordinated could agree on a cause, agree on a message, a bit of political rhetoric, and a program that could be brought to state legislators and to federal legislators, especially with some elections coming up, that could have a real impact. So I believe twofold: one, the leadership in the sector, and second, motivating, mobilizing, and providing a direction for a groundswell of activity among consumers and their family members.
Thank you. So now we have another question, which is, would you agree that the root cause of these problems is ageism?
I think ageism is certainly a part of it. Ageism is baked into so much of what we do. It's extremely difficult to identify it. It's one of those intrinsic biases which soak into many, many things that we do. And yes, I believe, and this may come across as harsh, I believe that if you're old in the United States and the UK, if you're old and you're poor and you're somewhat disabled, you are immediately placed in a lower class. You are discriminated against at multiple levels, at multiple touch points along your journey of life because of those three factors alone. And that to me is an ethical issue, a moral issue, but more importantly, it's a strategic economic issue. It's a mistake of the first order, because those three pieces, I would call them neglect. Those three pieces of neglect are expensive and damaging to the very fabric of society. So yes, I think ageism is one of the root causes, but it's not the root cause of how we got to where we got today.
Thank you, Irving. So we have time for one more, and I can see that there's quite a few others which we will get back to after this live event. So thank you for all your questions. So the final question is, US senior living has suffered a disproportionate number of deaths from COVID. What does the industry do to prepare for the next pandemic?
Okay, what a terrific question. So there are very, very smart operators out there who understand what needs to be done and who are going about doing it very quickly, swiftly, and competently. And I'm absolutely proud to say that I know and work with a number of them. I believe that I'm going to tell you a story about Mercedes-Benz. In the late 1950s, early 1960s, I think it was, Mercedes secured several international patents on anti-lock braking systems. And instead of controlling those patents and limiting their use, they granted anybody who wanted access to those patents, they granted them access to those patents, which is why today we've reduced road fatalities. Airplanes have anti-lock brakes, as do trains. So the dispersion of that technology was very quick because one organization had the insight and the ethics to say, this is too important to keep to ourselves. Similarly, in long-term care, we're learning lessons about how to manage the movement of people around a building. We're learning lessons about how to supply those people with masks and covering, what are referred to as personal protective equipment. We're learning lessons about how to manage a food service inside of a congregate care center. It's extremely important, and yet also a potential vector for infectious diseases. There are people who are learning how to do these things, doing very clever things with ventilation and air conditioning and UV lights and all this stuff. It's great stuff. My hope, my initiative, my urging is that all of these are dispersed broadly and not withheld by certain operators because they believe it gives them strategic advantage. Please, all of you, remember, this crisis isn't a crisis of one operator. This isn't just affecting a Genesis or a Sabacare. This is affecting the entire sector. And if we don't address it in its entirety, it will come back and bite us again. And yes, there will be other infections, maybe not pandemics, but there will be other episodes of contagion. And we as a sector really need to be prepared to say, got this, guys. This is what we learned, and this is what we're doing. You can trust us. That's so critical. So I hope I responded to all the questions. I want to thank you all for excellent questions and for your patience. And I'll look forward to being in touch with some of you individually and all of you again for another webinar. Please stay well, all of you, and happy holidays. And we'll connect again in 2021.
Thank you very much, Irving. Thank you all for attending today's webinar. We do hope you found it informative. And please do take a moment to tell us how we did. We'll be asked to fill in a very brief survey at the end of the webinar. This is the only way we can learn how to improve our presentations. Thank you again. And please do email or message in your NAB ID. I thank you to those who have done so already. I will make sure to mark your attendance. Thank you again, and we look forward to seeing you at a future program. Have a great day, evening, afternoon, and stay well, everyone. Thank you.